Respected audience, Assalamu alaikum. I am Professor Shamsuzzaman, Professor of Pathology. I welcome all in today's 15th lecture on systemic pathology. Today, day 4 of diseases of liver. Day 4 of diseases of liver. Dear audience, today's topic is cirrhosis of liver. First come to what we mean about cirrhosis of liver. I mean, what is the definition of cirrhosis of liver? A generic term for liver disease of varied etiology characterized by extensive fibrosis, regenerative nodule formation, abnormal arteriovenous interconnections, abnormal arteriovenous interconnections, and disorganization of hepatic architecture. Is known as cirrhosis of liver. Dear audience, it is a generic term for liver disease of varied etiology characterized by extensive fibrosis in liver, formation of regenerative nodule in liver, formation of abnormal arteriovenous interconnections in the liver, and disorganization of hepatic architecture, and this is known as cirrhosis of liver. Dear audience, if this is liver, there will be extensive fibrosis within the liver. There will be formation of regenerative nodule. There will be abnormal arteriovenous interconnections and disorganization of the hepatic architecture. It is known as cirrhosis of liver. It is a generic term for liver disease of varied etiology. Now come to classification of cirrhosis of liver. Classification based on size of nodule and classification based on etiology. Based on size of nodule, classification based on etiology. Based on size of nodule, micronodular cirrhosis. In this type of cirrhosis, the size of nodule is less than 3 millimeter diameter. Size of nodule is less than 3 millimeter diameter. Dear audience, micronodular cirrhosis is usually associated with alcoholic type of cirrhosis. Macronodular cirrhosis size of nodule is more than 3 millimeter diameter. Dear audience, macronodular cirrhosis usually found in post-necrotic type of cirrhosis. Based on etiology, that is etiological classification of cirrhosis. Post-necrotic cirrhosis, post-necrotic cirrhosis usually found following hepatitis caused by virus B and virus C. Usually found following hepatitis caused by virus B or virus C, that is cirrhosis following hepatitis caused by virus B or virus C is complications of hepatitis caused by virus B or virus C. Alcoholic cirrhosis that is found in chronic alcoholics. Cirrhosis in nutritional deficiency. Dear audience, cirrhosis found in protein energy malnutrition is an example of cirrhosis in nutritional deficiency. Example, cirrhosis in protein energy malnutrition. Post-necrotic cirrhosis, alcoholic cirrhosis, cirrhosis in nutritional deficiency, biliary cirrhosis, pigment cirrhosis, cirrhosis associated with Wilson's disease, cirrhosis associated with Wilson's disease, cirrhosis associated with alpha-1 antitrypsin deficiency, associated with alpha-1 antitrypsin deficiency. Dear audience, based on etiology, post-necrotic cirrhosis, alcoholic cirrhosis, cirrhosis in nutritional deficiency, biliary cirrhosis, pigment cirrhosis, cirrhosis associated with Wilson's disease, cirrhosis associated with alpha-1 antitrypsin deficiency. Dear audience, I have told you pigment cirrhosis. Such type of cirrhosis is found in hemochromatosis. Found in hemochromatosis. Dear audience, now come to hemochromatosis. Hemochromatosis means iron overload disorder characterized by deposition of ferritin and hemosiderin in tissue and causes tissue injury. It is iron overload disorder characterized by deposition of ferritin, hemosiderin in tissue and causes tissue injury. This is hemochromatosis. It is iron overload, deposition of ferritin and hemosiderin in tissue, and this deposited ferritin and hemosiderin causes tissue injury. Dear audience, hemochromatosis may be primary hemochromatosis, the cause is not known, and it may be secondary hemochromatosis. Secondary hemochromatosis usually found in thalassemia, a type of congenital hemolytic anemia. It may be primary hemochromatosis, cause is not known. It may be secondary hemochromatosis, secondary hemochromatosis may be found in thalassemia. So, hemochromatosis is iron overload disorder. Dear audience, now come to triad of hemochromatosis. Triad of hemochromatosis: pigment cirrhosis, dear audience, deposition of ferritin and hemosiderin in hepatocyte. There is injury of the hepatocyte. Ultimately, there is destruction of hepatocyte, and there is fibrosis. Deposition of ferritin and hemosiderin in hemochromatosis. In liver cell injury, ultimately there is fibrosis. Fibrosis in liver, and this fibrosis in liver is nothing but cirrhosis in hemochromatosis, and this is pigment cirrhosis. So one of the triad is pigment cirrhosis. Another of triad, diabetes mellitus. Dear audience, deposition of ferritin and hemosiderin in pancreas leads to injury of beta cells, decreased insulin synthesis, decreased insulin secretion. There will be hyperglycemia and diabetes mellitus. Dear audience, another triad of hemochromatosis, skin pigmentation. So, triad of hemochromatosis, pigment cirrhosis, diabetes mellitus, and skin pigmentation. Dear audience, if anybody suffers from diabetes mellitus and skin pigmentation in hemochromatosis, such type of diabetes mellitus is known as bronze diabetes. Again, if anybody suffers from diabetes mellitus and skin pigmentation following hemochromatosis, such type of diabetes mellitus is known as bronze diabetes. Dear audience, I have told you cirrhosis associated with Wilson's disease. Now come to Wilson's disease. It is an autosomal recessive disorder of copper metabolism. An autosomal recessive disorder of copper metabolism characterized by deposition of toxic level of copper in tissue like liver, brain, eye. So it is an autosomal recessive disorder of copper metabolism characterized by deposition of toxic level of copper in tissue like liver, brain, eye. Dear audience, we want to recapitulate the copper metabolism. Absorption of copper, uptaking of copper by hepatocyte, uptaking of copper by hepatocyte, secretion of copper from the hepatocyte along with ceruloplasmin, secretion of copper from hepatocyte along with ceruloplasmin. This ceruloplasmin is carrier of copper. Again, absorption of copper, uptaking of copper by hepatocyte, secretion of copper from hepatocyte along with ceruloplasmin, and ceruloplasmin is a carrier protein. Dear audience, in Wilson's disease there is deficiency of ceruloplasmin. In Wilson's disease, deficiency of ceruloplasmin. Due to deficiency of ceruloplasmin, copper is deposited in tissues. Like liver, brain, eye. When it is deposited in liver, it leads to liver cell injury, ultimately cirrhosis. When it is deposited in the basal ganglia of the brain, it causes degeneration. Deposition in liver leads to cirrhosis. Deposition in basal ganglia leads to degeneration in basal ganglia. This is known as hepatolenticular degeneration. Known as hepatolenticular degeneration. This is Wilson's disease, in which there is cirrhosis of liver due to copper deposition. Dear audience, if anybody suffers from cirrhosis of liver, whatever may be the cause, what may be the morphology of liver in cirrhosis? Now come to morphology of liver. Gross examination reveals firm liver, contracted liver, and surface nodularity of liver. Dear audience, on gross examination, we get the consistency of liver is firm, liver is a bit contracted, and there is surface nodularity. Fine needle aspiration cytopathology reveals, FLC reveals normal looking hepatocyte. Along with normal looking hepatocyte, there is stromal cells. These stromal cells indicate it is fibrosis. It is fibrosis in liver. Histopathology reveals extensive fibrosis. Regenerative nodules. Area of extensive fibrosis. formation of regenerative nodules. These are the hepatocytes. Dear audience, this is extensive fibrosis. These are the regenerative nodules. This is the histopathological findings of cirrhosis of liver. Dear audience, I have told you regenerative nodule. What is the difference between regenerative nodule and hepatic lobule? Dear audience, you know hepatic lobule has central vein, and from the central vein these are the hepatocytes. This is the central vein containing blood. But regenerative nodule is devoid of central vein. Devoid of central vein. Again, hepatic lobule contains central vein, but regenerative nodule does not contain any central vein. So morphologically, on gross examination, liver is formed, contracted, surface nodularity. FNAC reveals normal looking hepatocyte, stromal cells. Stromal cells indicates there is fibrosis within the liver. Histopathology reveals extensive fibrosis, regenerative nodule formation. Dear audience, now come to laboratory diagnosis of cirrhosis of liver. How can we diagnose cirrhosis of liver in laboratory? Blood examination, biochemical test, ultrasonography, CT scanning, biopsy and histopathology, ascitic fluid analysis if patient is complicated with ascites. First come to blood examination. Hemoglobin, it is reduced. Patient suffering from cirrhosis of liver suffers from anemia of chronic disease. ESR is high as there is decreased albumin synthesis, there will be high ESR. Peripheral blood film. Dear audience, you know anemia in cirrhosis of liver is anemia of chronic disease. So peripheral blood film shows microcytic hypochromic RBC. Microcytic and hypochromic RBC. Dear audience, along with microcytic and hypochromic RBC, we'll get target cells. Dear audience, you know we get target cells in thalassemia and also in liver disease. Now come to biochemical tests. Total plasma protein. Dear audience, in cirrhosis of liver, as there is reduction of hepatic mass, so there is decreased synthesis of albumin. Due to decreased synthesis of albumin, total plasma protein is decreased. Serum albumin, it is decreased. If we do albumin globulin ratio, dear audience, you know normal albumin globulin ratio is 2:1. As there is decreased synthesis of albumin, there will be decreased albumin globulin ratio. Albumin ratio globulin, albumin globulin ratio is decreased. Now come to ascitic fluid analysis. If patient is complicated with ascites, then there is question of ascitic fluid analysis. Biochemical test. Protein in ascitic fluid is decreased. It is less than 3 gram per deciliter. Dear audience, as there is decreased synthesis of albumin, so protein is decreased. Glucose in ascitic fluid, it is almost normal. Bacteriological test. Zell-Nelson stain for acid fast bacillus not found. Gram staining reveals no organism. Zell-Nelson stain reveals no acid fast organism. Gram staining reveals no organism. It means this ascites is not due to infection. Now come to cytology of ascitic fluid. Cytology of ascitic fluid reveals reactive mesothelium. It also reveals mononuclear cells like lymphocytes, and negative for malignancy. So cytopathology reveals reactive mesothelium, mononuclear cells like lymphocytes, no anaplastic cell or malignant cell. This indicates this ascites is not due to intra-abdominal malignancy. Dear audience, we can estimate ADA in ascitic fluid. It is an enzyme. The enzyme is adenosine deaminase. You know, it is mainly secreted by macrophage and also by lymphocytes. ADA is increased in ascitic fluid when this ascites is due to tuberculosis. As this ascites is not due to tuberculosis, but this ascites is due to cirrhosis of liver, so ADA is not increased. Again, ADA, adenosine deaminase, it is an enzyme. It is mainly secreted from the activated macrophage. Also from the lymphocytes. And this adenosine deaminase is increased in tuberculosis. As this ascites is not due to tuberculosis, rather it is due to cirrhosis of liver, so ADA level is not increased in ascites. Dear audience, today I have told you about the cirrhosis of liver, classification of cirrhosis, morphology of liver in cirrhosis of liver, laboratory diagnosis of cirrhosis. Now come to complications of cirrhosis. One of the important complications of cirrhosis is ascites. And another complication of cirrhosis is hepatocellular carcinoma, HCC, hepatocellular carcinoma. Dear audience, I have discussed today cirrhosis of liver briefly. Today up to this, thanks all.